Welcome back, everyone. We're going to continue the pediatric series with discussing neurologic emergencies. Neurologic emergencies can be benign, but they also can be life-threatening. Medical history is going to be important with your neurologic patients, pediatric patients and adults alike. And it should include things like previous seizures, shunts, history of cerebral palsy, recent trauma, or ingestions, as toxic ingestions can certainly have neurologic implications in presentation. Conditions that interfere with mental status are known as a state of altered mental status, and causes can be including things like metabolic problems, infectious disease, intracranial structural abnormalities, trauma, hypoxia is a big one. We talked about that in respiratory and cardiac, as well as poisoning. You can use the mnemonic AEIOU tips. We saw this in our adult neurology discussion, and to help quickly remember some of the common causes, right? So alcohol, epilepsy, insulin, so hypoglycemia or hyperglycemia, oxygen, uremia, trauma, infection, pneumothorax, any number of things can cause that altered mental status. And remember that particularly in your pediatric patients, they're large cerebral consumers of oxygen. So anytime that there's hypoxia present or a condition that may result in reduced circulation, altered mental status is going to be present. And pay attention to dextrose as well. Check glucose. Remember, babies, pediatric patients, high consumers of fluid, high consumers of oxygen, high consumers of sugar, and they don't have a great way to store any of those. And so they run through those reserves relatively quickly. For altered mental status, supportive care includes, right, airway, breathing, and circulatory status, just like with every patient. But if hypoglycemia is present, give glucose. If sign and symptoms suggest things like opiate toxidromes, then consider medications like naloxone or Narcan. Transport all patients expeditiously with altered mental status, particularly for pediatric patients. This is oftentimes an ominous sign of an underlying pathophysiology that may need further diagnostics or more aggressive treatment. Assess for increased intracranial pressure. You can remember things like Cushing's triad here, right, which denote herniation syndrome and increase intracranial pressure. That's the increase in blood pressure, the decrease in heart rate or the widening of the pulse pressure, and the irregular respiratory pattern. Seizures in the pediatric patient are common complaints that we go to, secondary to respiratory, but certainly one of the more common things that we see. Remember that it results from an abnormal electrical discharge in the brain. It can be predisposed or result from things like trauma, underlying metabolic disturbances, particularly glucose, ingestion infection, as well as hypoxia. Physical manifestation of a seizure will depend on the area of the brain affected. We discussed in our medical series about things like focal motor seizures or generalized or tonic-clonic seizures. And remember that generalized seizures involve the entire brain, while partial seizures are only part of the brain. And you can have things like simple partial seizures where there's no loss of consciousness, or complex partial seizures, which has a loss of consciousness as well as focal motor activity. Febrile seizures are common in children and one of the common seizure types that we respond to. For it to be considered a febrile seizure, the child must be between the ages of 3 months and 6 years, and they must have a fever and no other identifiable precipitating cause of the seizure itself. It's a diagnosis by rule out, meaning that we have all of these things present and we've evaluated for other things. The patient's not hypoxic, hypoglycemic. There's not underlying neurologic conditions that are going on. This is when we would come to the conclusion that it would be a febrile seizure. Strongest predictable history or strongest predictor as far as history goes for the patients is a first-line relative with a history of febrile seizures. So direct sibling, mom or dad had a history of febrile seizures. That would be a good indication that the patient would be at risk for febrile seizure. Simple febrile seizures are brief, generalized tonic-clonic seizures occurring without any underlying neurologic abnormalities, while complex are longer. They're focal or oftentimes focal seizures and occur with baseline development or neurologic abnormalities. For assessment, right, we've talked about seizures before. Oxygenation is key. When your patient is seizing and their diaphragm is seizing, they can't ventilate. If they can't ventilate, they can't oxygenate. So care should be based around protecting the patient and making sure that they have the area where they can seize without becoming injured. As well as ensuring the adequate supply of oxygenation. Anticonvulsant medications or prior seizures can be an indication or an assessment tool for you in the history phase for gaining the likelihood of seizure. Make sure that we're asking about the duration of seizure activity from on-scene providers or caregivers, as well as asking about the character of the seizure. If a patient has a history of seizures, was this seizure normal for them? Oftentimes, if it's an underlying disease process, things can progress and change. And therefore, the patient may have undergone different seizure activity than is normal for them, and that may be the cause of EMS being called out there. Treatment is limited to supportive care, right? Supplemental oxygen, ventilate if it's indicated for hypoventilation and the patient is hypoxic. For ongoing seizures, you may need to suction secretions. Do not attempt endotracheal intubation during an active seizure. Make sure we're measuring glucose. For advanced level providers, you may be considering things like benzodiazepines to help break the seizure activity. Meningitis is an inflammation of the meninges. It's rarely, a viral meningitis is rarely life-threatening, while bacterial meningitis is life-threatening. You're not going to be able to differentiate between the two on scene. You should treat all meningitis as bacterial meningitis until proven otherwise, and that includes appropriate spread the virus protection, making sure that you are using appropriate PPE and droplet precautions and so forth. Symptoms can vary, and in the young child, they can be really, really vague. Meningitis can cause sepsis, and it's often characterized in the neonate or pediatric patient or newborn by petechial purpuric rashes. And this is an example of a baby with purpura here, and this is hallmark of meningitis. Infection control is important. Signs and symptoms include things like fever, altered mental status, a bulging fontanelle, which would be a sign of increase in cranial pressure there. Photophobia or sensitivity to light, nuchal rigidity, and shock. Make sure you're monitoring glucose. Provide life-saving interventions as needed. Right? Support airway breathing and circulation. The patients may need oxygen, airway management, and ventilatory support. Hydrocephalus is a disease that results from impaired circulation and absorption of the cerebral spinal fluid. This leads to increased cerebral spinal fluid in the ventricles and an increase in intracranial pressure. This is often identified prior to EMS arrival, and patients will already have a shunt. And you should be asking about the shunt if you indicate or suspect increase in cranial pressure in a patient that's presenting to you. This should come up in common conversations. Caregivers are, notified to inform providers that this exists because they can certainly provide complications, and shunts do malfunction, and that's when we see some of the greatest problems here. There are two types of shunts. You've got VP shunts. I'm not going to try and pronounce that word, and VA shunts. Complications for the cerebral shunts include infections, blockages, overdrainage. More often than not, the complication is the failure of the shunt to drain. So the purpose of the shunt is to drain cerebral spinal fluid into the abdominal cavity to subsequently be absorbed and excreted accordingly. But when those shunts fail, it leads to significant increase in intracranial pressure. And signs of that include early signs of increased intracranial pressure, so things like headache, vomiting, altered level of consciousness, and visual changes. If it's not immediately rectified, and it has to be rectified through surgical measures, it's not something you're going to be able to do pre-hospital, that increase in intracranial pressure that's being caused by the shunt or the overproduction of CSF can lead to ultimately herniation syndrome and death. Manage increased ICP with the best of your ability and transport the patient immediately to a facility with neurosurgical capabilities. Communication is going to be key for these patients. They need to have a neuro team prepped and ready on your arrival, so make sure you're conveying the appropriate information to the receiving facility. Traumatic brain injury is head trauma is common in childhood, and a small number of children who appear to be at low risk may have an intracranial injury. Evaluate any child with a head injury for signs of potential abuse. And we've got a separate lecture that will talk about child abuse specifically and identifying some of those causes. Remember that regardless of the cause, your responsibility is to treat the patient and treat accordingly. Epidural hematoma is when there's a hemorrhage in the space between the dura and the skull, with subdural being below the dura, or between the dura and the arachnoid membranes. You can suspect abuse, but it doesn't change your treatment of the child. So treat your patient, okay? Child abuse does account for a significant number of cases of epidural hematomas and subdural hematomas in children, and it's probably the most common cause. You still have to treat your patient. You still need to get rapport with the caregivers on scene. Your ultimate responsibility here is to try and get the patient to a receiving facility, to a neutral environment that, one, we can treat the child, treat the patient accordingly, and then we can engage additional resources for the child to take appropriate actions regarding at-home care, at-home life. Management for TBI includes stabilization of airway, breathing, and circulation, and frequent neurologic checks. With traumatic brain injury in children, it's not uncommon to see things to go south relatively quickly with patient presentation. That increased intracranial pressure can create things like seizures, and seizures can lead to hypoxia. Hypoxia leads to further seizures and bradycardia. So be aggressive in your assessment and your treatment, and move expeditiously to an appropriate facility.